I'm very pleased to be here today for very obvious reasons. Having been in this field for a very long time, it's very gratifying to be here today. The session is entitled Living with Pompe's Disease, and I'd like to somewhat modify that and say recognize the fact that we now have enzyme replacement therapy, and say that it could be modified to what can we do additional to enzyme replacement therapy. And I say that because of some of the comments that were made during the earlier sessions. So, and this session will address some of the issues that were raised really in some of those earlier sessions. For example, that raised by Priya when she talked about hearing problems, which impacts on speech, which will be discussed in this session. The complex issues that are related to pulmonary directed therapy, which will be discussed by Dr. John Bach, also in this session. The speech will be discussed by Sharon Veis. The ranges of the ravages of immobility, which were raised by Hans van der Ploeg, and the role of physical therapy will be discussed by by Dawn Phillips. And another issue which was raised during the questions, which was related to nutrition and also possible alanine supplementation, will not be discussed during this session, probably because this is an issue which is rather complicated and on which there is currently no really consensus of opinion. And lastly, we will hear about the marvelous natural history project and the results of that. That's our first speaker, who will be our last speaker, and I look forward to that. So I will now, without any more ado, call on our first speaker, who is Arlene Veis, who is a noted and highly respected speech therapist and pathologist, as to address those issues.
My name is Sharon, and I would like to discuss speech and swallowing issues in the neurologic/metabolic population. It's a talk that's, I think it spans the diverse nature of the diseases, the disease here that we're discussing, Pompe disease, as well as the diverse listeners that we have here. I know that there are some patients, affected patients, late onset. I know that there are some parents of children who have infantile onset. So it's really not a unilateral or a uniform, whoops, wrong thing here. And I'll use this.
Use the arrows.
Use the arrows. Got it. Speech and communication issues can be encompassed by some of these things here. You look at both acquisition versus degeneration. It's not just the learning of language. In other situations, it is how the deterioration happens over the course of a disease, as well possibly the course of a lifespan. So it's hard to discuss speech and communication issues in one way. You also need to look at the structure versus the function of the speech mechanism itself, and I'll talk a little bit about that more. You have another issue, clarity or articulation. So how clear is one's speech versus the content of the language. So when we talk about speech or a speech pathologist, it's not only the speech, meaning the speech sounds that we do use in all different languages, but the content. And then we have another issue here, oral speech versus augmentative or alternative communication. Oral speech is how we produce voice in the usual sense, and I'll talk a little bit about that more. And if you can't produce speech in the traditional sense using your voice, what are the other options? There are lots of different options nowadays. There's both gestural communication, using your hands for sign language, for example, that some patients may be using, or more sophisticated devices including all different kinds of computers, from very small portable computers to very sophisticated laptop computers, and they can be accessed in all different manners. So I'd like to touch on some of these things here. Speech is multifaceted, and I've listed here how really the speech mechanism works. The respiratory control drives the phonatory or the voice control. Once you have an air stream and your vocal cords vibrate, that's what produces the sound. At the minimum, it's an ah or an o or just some kind of vocalization. And once the vocalization is then modified by the oral motor or the mouth system, it translates or it becomes what we know of as speech. So lots of people can produce a minimum of vocalization, but human beings are able to modify the system. It is shaped by the lips, the tongue, and the palate, which then provides us with different resonance balance. Here I have listed some structural versus functional differences. The structures, as I said, we have the lips, the tongue, the palate, as well as the larynx or the voice box itself. They're isolated or multiple sites can be involved. Sometimes in a disease, just the tongue is involved, for example, or just the lips are involved. Or in a cancer of the head and neck, for example, just perhaps the larynx or the voice box is involved. Or in other diseases, such as Lou Gehrig's disease or other neuromuscular disorders, you may have effect of different sites. Can the structures be modified? Sometimes the structure, like the tongue, can be modified. Sometimes the palate, the function of the palate can be modified. But you often have to work within the confines of what the structure is. I have some listing here of the function. There may be changes in the strength of the musculature, and we often see that in Pompe as well as other neuromuscular disorders. You may have appropriate range of motion, but you may not have the strength of the muscle itself. I've listed the change in range. I said range or rate of movements. Sometimes speech can be clear, it can be produced, it can be intelligible, but it may be going at a very much slower rate, which then changes the intelligibility of the sound. And there may be changes in the effort of the task. Some people find it very easy to talk. Others may have to put much more effort in merely getting vocalization in order for it to be modified. Speech changes. Needs to be evaluated on an individualized basis. Everyone's speech in this room is very different, and same thing with a patient who may be affected by a disorder. You need to evaluate what are the structures and what are the functions of each of the different systems. The extent of the problem or differences determines the intervention strategy. What works for one person doesn't necessarily work for another person. Here we have in Pompe, there's great variability. And I'm learning more about the variability as I've met some of you here today, as well as reading some things in the literature about how things are affected. There's not much published information on changes regarding speech at the moment, other than possibly an enlarged tongue. I haven't come across any articles. In discussions with someone who works at Duke, she told me that there eventually will be an article that's going to be published soon to talk about speech and I think swallowing changes as well in this population. But right now, if you do a search, you don't really find anything. I think that makes it challenging for those speech pathologists and early interventionists who may work with patients who have these less typical diseases. How do we find out about them? In adults, there have been very few reported cases of macroglossia or that enlarged tongue. And here's a citation where they've listed 3 perhaps. And I don't know if anyone who's affected with the late onset disease here feels like their tongue often may be thick or Another way that we often think about it is your tongue is too big for the confines of your mouth. What do speech pathologists do in an evaluation to look at the speech and language function? What we look at, again, are listed on the left, the different structures. And I usually like to think about the structure and then the function. So if we have the lips, we look at to see what do the lips look like. Do they touch each other at rest? Do they touch each other during movement if you're asking them to produce, let's say, repeated alternated movements? The tongue itself, what does it look like? What is the bulk of the tongue? Does it come out of the mouth because maybe the lips don't come out, the lips don't close, sorry. What does the palate look like? That's the little muscle, we call it the velum, the uvula, the soft palate. It's the little muscle that when the doctor says, say, ah, you're looking to see whether that muscle is retracting, lifting upward and backward in order to close off the nasal passageway from the oral passageway. And this is what leads perhaps to nasality of speech, when there is muscle weakness in the palatal function. So the air, as opposed to being shunted out of the mouth, it then gets shunted up through the nasal passageway and causes resonance or movement of the air out that way, and then you have nasality of speech. There are two different qualities there. There's nasal air emission, when you have air on a vowel sound, or you have nasality, which means some of the oral consonants become nasalized. We also have the larynx or breath support, and this leads to changes perhaps in the vocal quality, roughness of speech, breathiness of voice, hoarseness, those are the terms. There's also strained and strangled voice qualities when there is too much muscle tension in the voice itself. So we do look at the range of motion. Tasks for the lips would be rounding and smiling, for example, and then going back and forth and seeing how quickly can the muscles do that and how well they do it if you go faster. The speed of movements, again, I just mentioned that. Sometimes in muscular diseases, the faster you go, the less precise you become, and often there's a give and take. Do you go faster to get the message out faster, or do you have to slow your message down in order to become more clear? With the tongue, we may have the person stick out the tongue and move it laterally back and forth, and we may ask them to do lingual palatal contacts, and that means the tongue lifts up and touches the roof of the mouth for various speech sounds. The intensity. And that really encompasses the palate, so whether you have leakage of air through the nose can reduce the intensity, as well as the breath support. How much air are you taking in, and how much air are you giving out when you do talk? There are some people who are able to sustain an air stream for a fairly long period of time, but when they begin to modify it by moving the mouth and using speech on it, it often becomes much less effective. The last thing I'll mention here, we listen for vocal inflection or prosody. In some muscle disorders, the inflections, the tones, the highs and the lows of the speech also becomes very monotone. You might lose the highs and the lows of your speech, and that again can affect the way the speech sounds as well as the intelligibility. So there are different tasks that we look for all of these. This is a video print of a side view of the mouth. Very good. Okay. So this is a side view. This is the cervical spine right here, the different vertebrae. This here is the hyoid bone, which helps to lift the larynx. This is your jaw. You can see the teeth here, some with fillings. The tongue sits inside the mouth. This is, I'll also show a brief swallow study later. This is a bolus inside the mouth. The soft palate is right up about here. You can't see it very well on this, view, but the movement will lift up and back. This is the oral cavity, so the breathing happens down here. The vocal cords are right here, and air comes up through the lungs, vibrates the vocal cords here, and then air is shunted up through the mouth and gets changed by the speech sound that you make. And if you have excess nasality, this little muscle doesn't close, so instead of the air coming out the mouth here, it goes up and goes into the nasal passageway. All right, speech intelligibility. Is it a motor speech disorder or a developmental disorder? In some people, there is a developmental language disorder, speech and or language disorder that may make speech intelligibility a problem. In other people, it would be a motor speech disorder. So let's say they have speech, they've learned language, but there is some reason why the message is becoming less and less clear. We see that in lots of the neurologic disorders, multiple sclerosis, ALS. Even after a stroke, you can, again, you know your language, but you might have dysarthria, which is one of the motor speech disorders. There's another developmental disorder that may affect speech, and that is called apraxia or dyspraxia of speech, where there's a motor coordination problem. And I'm wondering that some of the language disorders may or may not be kind of superimposed on some of the motor speech disorders as well in this disease. Is intelligibility reduced? If so, by how much? If it's very minimal, maybe there aren't very many modifications that need to happen. If it's very, very affected, then we might, if it's affected by here rate and precision, we may want to make some modifications there. And these factors, rate and precision, certainly may be challenged by structural differences. We always look for structure as well as function. Okay. I think I went too far. All right. Speech issues in Pompe disease specifically. There is great variability, as I've said. With more severe Pompe stage, you might have more issues, including weakness. Is that the primary involvement? Is the primary involvement in the respiratory sense? If not, is it in the range of motion? Is the tongue actually able to move in all different directions? Or is there some inherent problem with the structure leading to functional problems? You may have lighter lingual palatal contacts or tongue to palate contacts, which then make the T's or the K's, which is, those are two different sounds where, for one, the front of the tongue needs to contact the roof of the mouth, and for the K, for example, the back of the tongue needs to contact the roof of the mouth. And if you have difficulties in making lighter contacts, that may lead to differences in production of sounds. Or again, is it a poor respiratory drive? I think that from what we've heard this morning, the effects of gene therapy on development and outcome certainly are going to be different than the babies who maybe have not been treated, or the children now who have not been treated. Are they going to look differently? Is their speech and language going to be less or more affected? From some of the information that I've learned, I think that it seems that the speech and language, they might have differences and some delays, more on the developmental delays as opposed to the disorder kinds of effects. With mild cases, a more traditional speech therapy focus on articulation within the structural capabilities. We don't have to work as much on language. We have to work more on, given what the tongue and the palate and the lips and everything else looks like, we need to do more traditional. So if you have a lisp, for example, and your tongue comes too far out of your mouth, we have to work more on that as opposed to other kinds of things. Respiratory involvement may lead to voice or loudness changes, or is respiratory involvement, will it lead to tracheostomy and ventilation? And in that sense, then we will need to look at other kinds of options. Standard tracheostomy shunts the air away from the vocal cords. It is now then a path from outside to inside. But what happens is that if the air is shunted out through the tracheostomy tube, it is not able to go traditionally up to the vocal cords in order for them to vibrate. If you have no vibratory source, then you have no ability to speak. There are some newer possibilities. Some are called, and I put it in quotes, talking trach tubes, where the air can be partially shunted through the tracheostomy tube, which then can lead to some vibratory source, which is then modified by the mouth again. We call it often leak speech. So you're getting some leakage from the ventilatory source up through the vocal cords in order to produce voice. It's not, it does not always work in people, and you need to work with the respiratory therapists in order to see if you're going to be successful or not. There's something called a valve that some people have. There are different brands. One is called the Passimir. There's also Bivona, where you can put on the end of the tracheostomy tube that then you can get air coming in through the tube, and what happens is that there's a small flange which then closes the tracheostomy tube, which then shunts the air up through the vocal cords and out of the mouth. So there are some different options if it's appropriate. If one is not able to talk in the traditional sense, sometimes we need to move to augmentative and alternative communication devices. I will first talk about gestural communication very briefly. For those people, both in this disease and others, if they're able to use some hand signs or gestures, whether it's traditional American Sign Language or not, sometimes we can use some gestural communication to kind of bridge the gap and give the child, for example, some way to communicate at least very simple things, more, all done, yes, no, play, milk, or whatever it is, in order to try to get some kind of communication, which really is the bottom line in all of this. Augmentative and alternative communication devices is an ever-changing field. When I started a long time ago, the smallest portable device was about twice the size of this laptop, and you had to carry it around, and the speech was not very good. Now there are so many portable devices, some as small as a handheld, like a Palm Pilot, that will produce all different kinds of voices, both child voices as well as adult voices, female and male voices, different languages, all different kinds of things, and the access methods that you use for them are also very varied. It does depend, however, on the cognitive abilities. The child cognitive abilities may be very different than an adult if you need to do that. Also for the teen, you might want to have different kinds of software on there. The other thing you have to look for is portability, which gets at home versus school needs if you're working with a child, or an adult. Do you need to have it in one room only if the person is not very mobile, or does it need to go with you wherever it is that you do want to go? Financial resources and funding is always a challenge, not only for children but also for adults. You need a lot of documentation in order to obtain a device for someone. There is insurance that covers. Medicare has guidelines which have come out in the last, I'd say, about 5 years, that if you have the appropriate diagnosis for a speech disorder, for example, anarthria or not talking anymore or significant dysarthria, and a physician's referral and letter of medical necessity, Medicare pays up to 80% of an augmentative communication system, with the 20% coming from additional or alternative funding sources. And this has been a big boon to a lot of patients at all different levels and with all different kinds of neuromuscular and other kinds of problems, including some stroke patients who may be left without a way to communicate. And there's a wide variety of different kinds of communication systems out there. Okay, device access. For those people who need an alternate method of communication, we have something called direct selection versus scanning. Do you have a movement of your hand or your body in order to touch the screen, for example, of what, let's say, little square which has information on it? Or do you need to use something that's called scanning, where rows are highlighted, and then you have to go through the row, and each different cell or button or square is then highlighted, and then you make a selection. Scanning is much slower. So again, you have to look at what kinds of your hand or extremity. There are also ways to access devices with other body parts. Your knee, your head, for example. There are head mouse now. And there's something relatively new called eye access. And that's where your eyeballs do, as I say, the walking. Your eyes can actually look at an on-screen keyboard, and wherever your eyeball goes, is what letter or square or whatever it is that you want will then be accessed. So that's direct selection because you're directly selecting the cell that you want, and some people are able to communicate that way. Those devices go from, I'd say, $5,000 to $15,000, and that's a constantly changing field. There's developments here all the time as well as overseas. There's a company that I know about in Sweden who's been trying to do some marketing. And in some of the other neurologic patients that I see, we do have some people who are using eye access for those people who are fairly immobile. Okay, I already talked about portable versus non-portable devices, and low-tech versus average versus high-tech. You need to make the appropriate selection. Some people just want a simple yes and no, and that may work fine. Sometimes we'll use an eye scanning device or an eye board, an alphabet board. Or do people want now to surf the net? They want to do everything. They want to send their emails, and they want to do all kinds of things. And there are some augmentative devices which will do all of that. Going to move now to swallowing. This is a big field which has been developed over many, many, many years. Swallowing involves the upper aerodigestive tract, very similar to speech. We have respiration, which involves the upper aerodigestive tract as well as swallowing. But each one works in slightly different ways. They may use the same muscles, but the muscles react in different ways or move in different ways. There are 4 phases of swallowing. We have the oral preparatory or chewing phase. It also involves the savoring of your food, the taste of your food. How well do you chew your food? We have the oral phase, and that really is when whatever you have in your mouth, whether it's liquid, something very smooth and creamy, or very chewy, it gets to be formed into we call a bolus or a ball. You have to have good tongue control in order to make it cohesive, in order for the tongue to then propel it into the throat area or the pharyngeal phase, which is the throat phase. And once it gets into the pharyngeal phase, it happens very fast. Within 1 second, whatever you have in your mouth should be swallowed. And then once it leaves the pharynx or the throat, it goes into the esophagus and then travels down the other part of the digestive tract. In a lot of patients that we see with neurologic problems and respiratory kinds of problems and general debilitation and weakness, a cough response to something that's noxious, like too much of a big sip of liquid, it may be impaired due to weak abdominal or intercostal muscles, and that can lead to lots of other medical complications. There might be multiple etiologies for the problems, so I've listed them here. I understand that in Pompe disease, reflux and problems with the GI tract is a factor, and in a lot of patients, both in premature babies, from premature babies all the way up through the lifespan, is a big factor. We see a lot of the swallow studies that we do at our medical facility for people who have generalized GI or other kinds of esophageal complaints that they think are manifested in sort of the mouth and the throat, where really they're mostly confined to the esophagus. Aspiration is always a concern. Aspiration is defined as liquid or food going below the level of the vocal cords. Nutrition is also a big factor. You need it for brain and body development in infants. You need to maintain your weight. You need adequate nutrition and hydration to make all your muscles work as best they can. And in Pompe disease, I know that nutritional needs may be more of a concern than actually able to swallow. There are people with Pompe's as well as other diseases that they actually have the appropriate function, but they don't have the efficiency. It takes too long or it's too tiring to meet all of the nutritional needs, and they need to move to something else even though they may have some of the function. 2 big factors here, safety and efficiency or inefficiency. How safe is the swallow and how efficient is the swallow, as well as how many stages are involved. If you're working with multiple stages, as I said, the oral, the pharyngeal phases, or the esophageal phases, how many stages? If you have 1 stage involved, sometimes that means a lesser problem. Sometimes it doesn't, because whatever is affected might be very significantly affected. Thorough evaluation is important. There's a bedside clinical evaluation that speech pathologists often do. We look at the oral structures, how the food and liquid intake. We often start in very small amounts, like a teaspoonful, and move up through cup drinking, for example. We may give pudding, we may give cookie or something else to eat. And we make our clinical judgment, we make our recommendations based on clinical judgment. It is, though, sometimes not entirely, what's the word I want to say? Clinical judgment, you can be wrong in your clinical judgment. The more experience you have and the knowledge of the disorder that you're looking at may lead you to suspect certain kinds of problems, but it's not foolproof, which is why we then have instrumental evaluation. Video fluoroscopic swallow evaluation, I'll show you what one looks like in a moment. It's an X-ray test, radiologic test, and it looks at the moving picture of how the mouth and the throat muscles work. There's another form, it's called a fiber optic evaluation of swallowing. Some people call it FEES, F-E-E-S, and that's where a scope is placed through the nose, over the soft palate, all the way down, and it looks at your vocal cord, through the level of your vocal cords, and they swallow some kind of material, and then you see what's left afterwards. Sometimes you can see whether aspiration has occurred or not. Possible swallowing problems. Oral initiation, so slowness in initiating muscle movements. Oral motility means sort of how it gets collected in a bolus or a ball inside your mouth. Sometimes there's premature spillage of materia where it starts to go over the back of your tongue before the swallow has happened. There can be pharyngeal swallow timing problems where the food can be propelled into the throat, but that the response of the muscles of the pharynx don't happen quickly enough, and that often can cause problems. You can have weakness of the throat muscles, and that causes pharyngeal clearance problems, so you'll have leftover food in different recesses in the throat. We also look at aspiration. When does it happen, how much, and what is the reaction, whether there's a cough or not a cough, and then we look at the overall efficiency. In Pompe, I have not come across any specific description of swallowing problems in the literature. Feeding difficulty in the large sense. A lot of the infants have feeding difficulties, and that probably, from an early sense, is the fact that their mouth muscles are not able to do the suckle part of feeding, which actually works very differently than the more mature pattern. If weakness is apparent, inefficiency may be as affected as the timing. So it might just be very effortful to eat, even though things might be working well. From anecdotal information, from what I've gathered, poor oral transit, so manipulation of the food inside the mouth, that would make sense, particularly if you have an enlarged tongue or the tongue is not working or it's weak. Delayed initiation of the swallow, so again, the food is held in the mouth in an attempt to get it to be more cohesive. There might be pharyngeal weakness, which leads to residue or leftover in various parts, and there may or may not be aspiration. And some of these problems co-occur. What do? Do we recommend oral feeding, or do we recommend some kind of alternative feeding once we do identify that there's a problem? Different kinds of feeding tubes may or may not be suggested, nasogastric, nasoduodenal tubes, or a gastrostomy tube which goes directly into the stomach. As much as possible, we like to try at the time of an assessment whether postures or maneuvers are successful. A posture can be as simple as tucking your chin down to your chest, which opens up a recess in the throat which is normally there to try to collect some of the material. A maneuver might be swallowing hard to try to help the pharyngeal muscles squeeze the food down better. Some of these are possible in different levels. For a very young child, they might not understand any of those things. Or do you think that they would be able to keep their chin down when they swallow or not? And exercise at a submaximal level may be limitedly effective in this disease. In other neuromuscular diseases, we often say that, yes, you may exercise, don't go all out and exercise, but it's really for maintenance of function as opposed to being able to build up the bulk of something which really isn't bulky anymore. So exercise at submaximal level might be appropriate. This black stuff is the barium that people swallow. Usually we start with a liquid. This is normal. It happens very fast. If you blink or you close your eyes or you look away, you've already missed it. This is an area called the vallecula that sometimes collects liquid or food. This is down here is called, there's recesses called the Piriformis Sinuses. Right here is approximately where the esophagus begins, and there's a little narrowing there. This is cup drinking now. Can't see too well in this, but there's a soft palate up here which closes off the nasal passageway to prevent liquid from going up into the nose. We occasionally see what's called nasal regurgitation, which means the food liquids up the nose. So again, very, very quick, very efficient. And here is another area that where we look for. These are the vocal cords right here. And there's an area here called the laryngeal vestibule, or the laryngeal entrance, the entrance to the larynx, which is right here. And what happens, this is cookie, so they're chewing. What happens is that this whole area here needs to close so nothing will leak down in there. Sometimes people, anybody here, if they take too big of a sip, they might get a little penetration here, so a droplet might go forward here and cause coughing or some other kind of reaction. It happens to all of us. What else do we have here? So you can see here the different facial structure of this person. Sometimes head position. This is the soft palate. I don't know if you can see that little muscle that moves right there. That's the soft palate, which then lifts and elevates and retracts here to close off right there. Not a very long tape, it's just another moment. And there should be some okay, I'm going to move it along and see if we can find the disordered. Now they're eating very fast. But again, you can see that, okay. This is, some of these are quite old, but this is where lip, having difficulty keeping the bolus in the mouth, and you can see the dripping there. So if you have poor closure of your lips, this is something that may happen right there. Swallowing apraxia is when the person is not able to get the bolus out of the mouth, and you see this kind of movement. There you thought that was going to happen because it was in a nice bolus there, but something doesn't lead to it there. And now once it gets initiated, the swallowing moves along. Okay. Let me go along and see what else I can find. Okay, we're going to skip through that one. This is what's called residue. I'm keeping it fast, though. This is residue. This is a lot of residue. Okay. Okay, I'm going to skip this one, too. I want to show some, just one more about what happens in the throat muscles. We often see a lot of complications. Okay, this is what I want. This is where the bolus is propelled out of the mouth and into the throat, but the swallow doesn't happen yet. So you're waiting and waiting and waiting, and now it swallows. Now you swallow. And this can if you have muscle problems in the tongue, this can often happen. This happens very frequently after strokes, for example. Waiting, 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 eventually the swallow will happen. And let's see if I can get to just one more example, and then I will. Oops. Okay, last one we'll say. This person has had a spinal surgery, very large. Very large. This is called reduced pharyngeal clearance. There's lots of residue here, and you can begin to see just a little bit of movement of the material. Okay, I'm going to stop there. Movement of the material into the airway entrance. And that is all that I have.
I want to thank Marilyn for having me come here and the committee, the program committee. And I have to say, I might as well start off by making a few comments on some of the things I've observed today. First, I saw this wonderful video where I saw a few patients there that really captured my interest. One was Morgan. I know Morgan captures everybody's interest. And I listened to the story. Morgan was using BiPAP for a year, and then she got a cold. And because she got a cold and her cough was weak, she ended up being intubated. And since the doctors didn't know how to extubate her to non-invasive aids, she ended up with a tracheostomy tube, which she didn't need then and doesn't need now any more than you or I need a tracheostomy tube. Then I saw a boy, right after her on the video, who's hooked up through the nose to a ventilator during the daytime, which is also strange. I don't know who that boy is, and I don't think he's here. Maybe he is. Anyway, nobody wants to be hooked up through the nose to a ventilator all day. He seemed to have very good lip muscle function, so he could have simply used the mouthpiece. But again, the doctors weren't familiar with showing him how to do that. And then we listened to a number of talks today, and frankly, I can comment on each one. Ms. Veis, if that's how you pronounce your name, I must just tell you that anyone who has enough bulbar muscle function, enough throat muscle function to speak, and certainly if they have enough function to swallow, they don't need tracheostomy tubes. Now, of course, that's not your fault. That's not your fault because you're not the doctor. And you can only deal with what you are left with by the doctors. And so then you have to look for Passimura valves, and you have to look for tracheal talks. All of these should be obsolete because anybody who can speak doesn't need a tracheostomy tube. That much I can absolutely guarantee you. And then we heard this morning that, well, for example, Priya mentioned a patient who wasn't a good responder. But I happened to see in that patient a nasal cannula, which meant that he was getting oxygen. So I immediately said to myself, that child doesn't have long for this world. Because if the physicians gave him oxygen, instead of putting him on ventilation that could help him breathe, obviously he was going to die or get trached very quickly. And then, of course, we heard also from Dr. Vanderpluk that many children die within 1 year of age. And she mentioned that many of them had received CPAP. Well, CPAP is not any better than oxygen, although it's not worse than oxygen. It means that the doctors don't understand that CPAP is completely useless for any of these children, that what they need is help for their inspiratory and expiratory muscles. So what is that help I'm talking about? And how can I be so sure that Morgan doesn't need a tracheostomy tube? Well, let's find out. First of all, oxygen therapy. In a study on over 700 ventilator users, we found that when a patient presents in respiratory difficulties and is sent home on oxygen, they're back in respiratory failure sooner than if they're not treated at all. You're better off doing nothing for your patient than putting them on oxygen because the oxygen is essentially putting a Band-Aid on a cancer. Now, what is the cancer? The cancer is underventilation and airway secretions. If you don't get the airway secretions out, you're going to develop pneumonia, or you're at high risk of developing pneumonia and respiratory failure. Is the oxygen treating that? Of course not. The oxygen is treating the oximeter. It's not treating the patient. By the way, patients on 24-hour non-invasive ventilation have fewer hospitalizations and pneumonias than patients who have trach tubes, even patients with trach tubes who don't use ventilators. That was also came out of this study, actually. How can I be so sure that infants with Pompe's disease can benefit from non-invasive methods to help them? Well, there's another disease that's much more common. I only have 10 patients with Pompe's disease over the last 5 years. Although one of them happens to be here today, and I'm very happy that she is, because you'll be able to see the kind of nose piece that we use on children overnight and on patients overnight. And that's Virginia Criswell, who's here in the back somewhere. At any rate, there's another disease too called Wernicke-Hoffman's disease, which is much more common. In fact, it's the most common cause of an inherited neuromuscular condition that can kill infants. And I have 110 of these patients. And if you look in the textbooks, they're all dead before 2 years of age. In fact, 90% are supposed to die by 1 year of age. Very similar to the statistics that you get with Pompe's disease. For me, there are three severities of Wernicke-Hoffman's disease. There's the child who is 24-hour vent dependent before they're 5 months old. They can't speak or swallow, ever. Then there's the child, and they go into respiratory failure and cannot breathe before they're 5 months old. Now, there's the typical type of Wernicke-Hoffman's disease patient, and they do fine until they get a cold, usually from about 6 months of age to about a year and a half. But then when they get a cold, because they can't cough effectively, they get pneumonia and go into respiratory failure, and then they die, or they get trached. Now, if they get trached, they're going to most likely die from complications of the trach tube on an average of 6 or 7 years. Although my oldest patient with the trach, with Wernicke-Hoffman's disease, is 23 years old, and he's been on 24-hour ventilatory support through his trach since he was 2 months old. So you can survive for a period of time. And it was actually at 23 that he bled to death from the trach tube. But on the average, it goes to about 6 or 7 years. Now, there's a mild type of Wernicke-Hoffman when, by definition, it's type 1 because they can never sit on their own and they cannot roll on their own. But they don't go into respiratory failure or perhaps need a gastrostomy tube until after the second birthday. That makes them extremely mild, and I don't count them because they're almost like SMA type 2s. Now, these children here, Michael now is 11 years old, and his brother is 6. They have severe Wernicke-Hoffman's disease type 1. They've been completely unable to breathe since they were 4 months old. They cannot speak. They've had gastrostomy tubes since they were 4 months old. Michael was hospitalized when he was 4 months old and put on nasal ventilation. That's the last time he's been hospitalized. His brother, Danny, who's now 6, no, I'm sorry, he's 8. I know that because he was hospitalized for the first time this year. He got a respiratory infection, developed pneumonia. He was intubated for 4 days, and then we extubated him back to non-invasive ventilation. That was the first time that Danny was ever hospitalized, which is really remarkable, and it means that the parents are very careful about not letting cold germs get into the house. That's really what that means. Many of our patients, though, have been intubated 10 or more times before their 4th birthdays. But each time, even though completely unable to breathe, our pediatric intensive care doctors extubate them back to non-invasive ventilation. And we get their airway secretions out by using a device that I'm going to talk to you about, which is called the cough assist. There are very few, if any, patients with Pompe's disease who are weaker than these children. Since before 4 months of age, they have not been able to move anything, and they have not been able to breathe at all. In fact, their measurable vital capacities now are under 30 milliliters. Okay. What about milder conditions? Well, there's a condition called Duchenne muscular dystrophy, which is the most common of all neuromuscular diseases. We haven't had to put a trach tube in any Duchenne patient's neck in over 25 years. And we have no respiratory mortality. Why? Because we teach them how to ventilate themselves non-invasively and also how to cough up their airway secretions when they get sick so that they don't get pneumonia. This patient now, for example, is 39 years old. He's been 24-hour vent dependent since he was 14 and a ventilator user since he was 12. But how does he use the vent? By having a mouthpiece in or near his mouth. He grabs the mouthpiece and gets deep breaths. And he's been doing this now for 26 years, something like that. 25, 26 years. So what is the big deal here? Well, the big problem is that physicians in general are used to treating lung and airways disease and not think in terms of muscle. And that patients with asthma, chronic obstructive pulmonary disease, bronchopulmonary dysplasia, cystic fibrosis, these are patients with lung and airways disease. And they're treated with oxygen and bronchodilators. And so when someone with Pompe's disease goes to a pulmonologist, since the pulmonologist is really familiar only with treating lung and airways disease, it's very likely that such a patient with neuromuscular weakness is also going to be treated with bronchodilators and oxygen. And the oxygen, of course, is not only not helpful, it's actually quite harmful because it turns off the patient's own breathing and allows the CO2 to go up to the extent that eventually the patients will not wake up in the morning. In fact, when patients go into ventilatory failure, such that they're obtunded and don't really wake up in the morning because they're comatose from CO2 retention, you can be sure it's because the physician put them on oxygen therapy. It's very rare. In fact, I cannot remember a case of this happening in a patient who was not receiving oxygen. So any patient with lung or airways disease will benefit from oxygen therapy and maybe bronchodilators. But patients who have a ventilation impairment need ventilatory assistance. Another problem is that pulmonary function studies are designed for people with lung and airways disease. Forced vital capacities, diffusion studies, these are all designed to look for airways, lung and airways disease, which has nothing to do with muscle weakness. I'm going to go over what is important to measure in patients with muscle weakness, and you'll see it's much simpler. When patients are given oxygen, all the symptoms of CO2 retention get worse. And besides this, there are some basic mistakes that we see all the time that you should be aware of. For example, anybody in a wheelchair about to perhaps go into respiratory failure is not likely to complain of shortness of breath. If we have a limited respiratory reserve and we're able to walk, we're going to complain of shortness of breath on exertion. But people in wheelchairs, their CO2s can go up gradually. They can get a cold and have difficulty coughing, and what they often say is that they feel anxious and can't sleep. Now, why do they feel anxious and can't sleep? Because their brain knows that if they fall asleep, they're not going to be able to breathe or cough so well. Because we don't recruit accessory breathing muscles so well when we're asleep as we do when we're awake. Also, our ventilatory drive and our cough is suppressed when we're asleep. So the patient doesn't tell us. What they tell us is that they feel anxious and they can't sleep. And very often what happens is the patient is given some sedative or is given oxygen, and they fall asleep and they arrest. And then, of course, they either die or they're intubated, etc. So a misinterpretation of symptoms is very common. Another common problem is that many patients with Pompe's disease, in fact, I would say perhaps the majority, have much lower vital capacity when you lie down than when you sit up. So some patients need ventilator use when they're sleeping, but not when they're awake at all, but not when they're sitting up. But pulmonary function studies are never really done with patients supine, or rarely, I should say, because some physicians are learning that it's important to look at vital capacity in various positions now. Monitoring sleep does not mean to do polysomnograms or sleep studies. These are an almost total waste of time and money, because the polysomnogram is only programmed to interpret any problem as central or obstructive apneas. It never tells, but that's like blaming the brain or the throat for what the diaphragm can't do. And people who order polysomnograms, the physicians who order them, also use inappropriate treatments like CPAP or oxygen or a low-span BiPAP, a BiPAP on minimal settings. So anyone that orders a polysomnogram is not familiar with how to treat neuromuscular weakness anyway. Almost certainly I can tell you that. There are very, very few exceptions, if any. In fact, if anyone thinks that they are an exception, I have one simple question. If you think you know how to use non-invasive ventilation, how many patients do you have on 24-hour non-invasive ventilation, including using a mouthpiece during the daytime? If the answer is 0, then you may be treating a patient for sleep-disordered breathing, but you're not preventing them from going into respiratory failure and dying or getting trached. So, do you need to monitor sleep? It can be helpful if you have a patient with questionable symptoms. Any patient who is symptomatic from the ventilation should try nighttime ventilation. And if they feel better using it, they will use it. If they don't feel better using it, then fine, don't use it. You don't need it yet, and don't worry about it. You don't need to do sleep studies. But if I have a question about if a patient is really symptomatic or not, I will do an overnight carbon dioxide monitoring, which is not part of normal polysomnography, and oxygen saturation monitoring, and that gives me the information that I'm looking for. Routine arterial blood gases are simply never warranted. In Chest, a pulmonary journal, some years ago, it was documented that 30% of patients who get stuck for arterial blood gases hyperventilate because of the pain. So it's much less accurate than simple end-tidal CO2 monitoring. And no one needs a tracheostomy tube unless your throat muscles are so bad that you not only can't speak or swallow, but that you're aspirating so much saliva that your oxygen saturation baseline stays less than 95%. Again, how do I know these things? Because I've published papers on every one of them. And this we published in 2004 in Chest, and we showed that for Lou Gehrig's disease patients are the only patients with neuromuscular disease who really do need tracheostomy tubes to survive, because they lose the ability to speak and swallow, and then they drip so much saliva into their airways that their baseline saturation goes below 95%, and within 2 months they'll be dead or trached, one or the other. That does not happen in any other neuromuscular condition, with very rare exceptions, including in the infantile Pompe's patients that I've seen so far. It doesn't happen in Wernicke-Hoffman's disease, which is why we now have over 110 of these patients, and I have 7 or 8 that are over 10 years of age now without trach tubes, even though many of them are 24-hour vent users. Suctioning should be done non-invasively, and we'll show you how to do that, because sticking catheters down people's throats or even into trach tubes doesn't get the job done. Why? Because when you put a suction catheter into the trach tube, 95% of the time it goes into the right lung for anatomical reasons. You have to have a special directed catheter to get it into the left lung. And anyway, it's uncomfortable and unnecessary, and nobody should ever be subjected to suctioning through the nose and mouth to try to get it passing the tube into the lungs. It's just not necessary, and makes it very difficult for the patients to breathe. Don't even think about oxygen therapy until you've done your best to normalize the oxygen by normalizing ventilation and cough, and coughing out the secretions. If you still need oxygen therapy because you have pneumonia, then you have to be in the hospital, and you better be sure that the physicians know that you're probably going to need to be intubated very soon. What's wrong with tracheostomy tubes anyway, other than the fact that they're foreign bodies in your neck, and they bring in very pathogenic bacteria? There's something called ventilator-associated pneumonia. That's a misnomer. It doesn't exist. The ventilator does not cause pneumonia, even though 100,000 people die in the United States a year because of ventilator-associated pneumonia. It's trach or interface-associated pneumonia, because if the patient is ventilated non-invasively, there's no such thing as ventilator-associated pneumonia. And many, if not most, patients can be ventilated non-invasively. It can avoid respiratory failure in the first place. In fact, in this paper that came out just last year, it showed that patients with trach tubes, even when they're not sick, have as great a burden of bacteria in their lungs as patients who have pneumonia. And the trach tube causes people to be dependent on the ventilator. So for example, Morgan, she just used nighttime ventilation for a year, and then she got respiratory failure and was trached, and when she was trached, she could no longer breathe on her own. At least she couldn't for very long. The reason for that is many. There are 3 reasons. 1, anybody ventilated through a trach, their carbon dioxide level goes down. They're hyperventilated. And when you're hyperventilated and you get disconnected, you cannot hyperventilate yourself. Because she could barely ventilate herself normally, she certainly can't hyperventilate herself. And that's why the trach tube causes people to become vent dependent. By bypassing upper airway sensory fibers, or whatever the reason, anybody on trach ventilation for a long period of time tends to have low carbon dioxide levels. That kind of hyperventilation cannot be maintained when they're disconnected, so the patients get short of breath right away and lose the ability to breathe on their own. Also, the trach causes the diaphragm to become deconditioned, and the trach causes airway secretions that block the lung to make it more difficult to breathe, and that also necessitates more ventilation. 17 to 65% of patients with trach tubes develop tracheal stenosis. When this happens, it's too late for the trach to be removed. And of course, there are many reasons of dying from trach tubes: fistulas, and bleeding, and hemorrhage, and infections, and so on. But the fact of the matter is the trach is simply unnecessary for almost all patients with Pompe's disease, if not all patients, and it can usually be removed when it's been inappropriately placed. In ALS patients, the average patient survived 6 years with the trach tube. But almost all of the ALS patients, the Lou Gehrig's disease patients, died directly because of the trach tube. Do patients prefer to have tubes in their necks than to use a mouthpiece or a Pneumo Belt during the day or nasal ventilation at night? The answer is absolutely no. In fact, it's unanimous that every patient who was decannulated and switched to non-invasive ventilation preferred it overall, and for security, convenience, comfort, appearance, speech, sleep, and swallowing. In fact, some patients with ALS, with Lou Gehrig's disease, when their throat muscles got so weak that they really did need a trach tube to survive, said that they would rather be dead than be trached again. All of us, we reach our peaks at the age of 19, and then we lose 1% of every organ in our bodies from the age of 19 on, including about 1% of our vital capacities. However, in patients with neuromuscular disease, they can peak younger and lose vital capacity more frequently. But this is the important thing. When the vital capacity goes below about 40%, the peak cough flows become non-functional. So, in other words, when you cough, you take a deep breath and then you cough. An average breath of air is about 500 or 600 milliliters. However, an average cough is 4 times that. Not many people know that. In fact, very few doctors know that because it's not that important to know. But nobody goes, we all go, we take a deep breath first. If a vital capacity is 500 milliliters, your ability to breathe may be normal, but your ability to cough is not going to be normal, even if you have intact abdominal muscles. So the first part of a cough is a deep breath. And you need to get a deep breath by being pumped up. And we'll show you how to do that. But let me go briefly as to how patients need to be evaluated for this. First of all, we measure carbon dioxide levels. If they're elevated during the daytime, they're higher at night. We do that painlessly and non-invasively with an end-tidal CO2 monitor, just by sampling the air that he's exhaling at the nose. And this works fine, and it's more accurate than an arterial blood gas. We also do oximetry. And we have a $15 peak flow meter, not to measure peak flows, but to measure cough flows. We not only have the patient cough through the meter, but we do an assisted cough where we pump the patient up with air, press on the belly, and measure that assisted cough. Because that assisted cough is only dependent on the glottic function. It's not dependent on anything else. So if a patient has a good assisted cough, the glottis is in great shape, and even if the patient can't breathe at all, he certainly doesn't need a tube and should not develop respiratory failure. But this peak flow meter is the most important thing, really, in the evaluation, because I can tell what your risk of pneumonia is just by looking at your cough flows. And the spirometer, vital capacity is what is useful to some extent. But with that being said, a vital capacity is not so useful because we have patients with 0 vital capacity for well over 50 years. None of them have tracheostomy tubes, and none of them ever will have tracheostomy tubes. Now, understand what I'm saying. A vital capacity is when you take as deep a breath as you can and you blow it into the spirometer, and you measure that volume of air. I have patients with 0 vital capacity, cannot move a milliliter of air, cannot breathe with respiratory muscles, in some cases back as far as 1947. None of them have tracheostomy tubes, nor will they ever have tracheostomy tubes for respiratory management. So of what use is a spirometer? Well, not for measuring vital capacity, but the spirometer is very important for measuring what we call the ability to air stack, or the insufflation capacity. Now, the person who's going to follow me is a physical therapist, and she's undoubtedly going to talk to you about stretching tight muscles. But I'm anxious to hear what she says about stretching the chest wall and the lungs, because not that many patients die from having stiff ankles, but if you can't get a deep breath to cough with, you're in big trouble. So the number one goal is to optimize chest wall, to mobilize the chest wall and lungs. And for children with Pompe's disease, it's extremely important because the lungs grow until the alveoli and part of the lung multiply until we're 7 years old, and they grow until we're about 17. When you see a baby who's not affected cry, what do? They go, wah, right? The whole chest comes way out like this and the belly goes out. When the child with Pompe's disease cries, what happens? The belly sinks in, the belly goes out, but the chest sinks in. The lungs do not grow. As soon as a child is diagnosed with Pompe's disease and you see paradoxical breathing, the chest, when the belly goes out, the chest goes in, you have got to put that patient on BiPAP. I don't care if the patient is 2 months old. It's not to help them breathe. It's to give them deep breaths so that their lungs grow. Okay? That's the main reason. And that's mobilizing the chest wall and facilitating lung growth. And I can tell you right now that you will not develop a funnel-shaped chest or a pectus excavatum with the center of the chest sunken in if you use high-span BiPAP at night for any child with neuromuscular disease who has paradoxical breathing. Okay? It's extremely important. For older patients, we can teach them how to air stack and get real deep breaths and maintain their lung compliance that way. The second goal is to optimize cough flows, and then third, to maintain ventilation. But first, let's look at the older patient who needs to have range of motion of the chest wall and lungs. We use an AMBU bag, a manual resuscitator, put a mouthpiece on the end of it, or you can do this through a nose piece or a lip seal, and we literally pump the patient up. His vital capacity is 500 milliliters. He can get pumped up to a maximum insufflation capacity of 1.5 liters by holding the air with his glottis. And this patient is a Duchenne patient who's 44 years old. He's been 24-hour vent dependent since he was 23. You will never see a trach tube in his neck. He is showing how to use air stacking by using this manual resuscitator. and another patient, and now after the lungs are full of air, they blow it into the spirometer. This is the maximum insufflation capacity. In fact, for you physicians out there, the maximum insufflation capacity minus the vital capacity is a direct correlate of bulbar muscle function, of the glottis, the power of the glottis. It's objective, it's reproducible, and it's better than any Norah scale or any other subjective nonsense that you find in the literature. If a patient's lips are too weak to air stack, you can use a lip seal and pump the patient up through a lip seal or a nose piece. And I'm going to tell you another thing, it's called frog breathing. Now, you may have thought I was only wearing this tie to be in fashion, but let me tell you, this is an instructional tie, okay? And you all need to learn how to frog breathe. Now, it's not that you didn't know how to frog breathe, you were doing it before you were born, but many of you may have forgotten how to frog breathe, or think that you forgot how to do it. But it's like riding a bicycle. Since you did it before you were born, I'm sure you can do it now. So this is what I want you to do now. Why is this important? Number one, you need to teach patients how to do it. Number two, if somebody steals a car and the cops smash into you, and you or me, and I become a C2 quadriplegic and have no muscles below my neck, well, if it happens to me, I'll be able to ventilate myself normally to the hospital. And if it happens to you and you can't frog breathe, you'll be very embarrassed that you didn't listen to me. Of course, you won't be embarrassed very long, maybe about 40 seconds, but anyway, that's enough time to be embarrassed. So this is what you do. There's several ways of learning this, but the best way is to just imitate me. What I'm going to do is I'm going to exhale passively to where my lungs are relaxed. Then I'm going to take about 15 gulps, and I'm going to exhale passively again. And that air that I exhale the second time, I will have gotten by frog breathing. Are you all ready? I'm going to... Okay, come on everybody, let's go. The group that frogs together stays together. You're not supposed to just watch me, you got to do this, No, really, there's not much time now. I don't have a lot of time, so normally we need to have a little workshop on this, all you frog breathers out there. But this is something that you can all learn. In fact, not only can you learn it, see, my vital capacity now is 4.8 liters. I can frog breathe up to 5.9 liters. But you don't realize it, probably, because many of you are not deep sea divers or competitive swimmers. But all internationally competitive deep sea divers are outstanding frog breathers, because when they go to 200 feet below sea level, on one breath, their lungs are totally squished. And they cannot get air up to equalize pressures in their sinuses, except by frog breathing, reverse frog breathing. And they can stay underwater an extra 50 seconds with the extra 3 liters of air they put into their lungs by frog breathing. So typically a person with a vital capacity of 5 liters can frog breathe to over 10 liters of air with practice, and they can stay underwater much longer. Every internationally successful competitive deep sea diver is an outstanding frog breather, and now the competitive swimmers are learning it too, because a 50-meter swim is done without taking a breath. And the more air you have in your chest, the more buoyant you are, the higher up you are in the water, and the faster you can swim. And these are articles that I'm actually reviewing for journals right now. That's why I know this. But anybody can do this, and you have to learn how to do it. Now, this patient here has a vital capacity of 900 milliliters, but she can frog breathe up to almost 3 liters. That gives her a deep breath to cough with. She doesn't have to call for help to get a deep breath to cough. She can get 3 liters of air into her lungs and cough just by frog breathing. This is one of my patients with 0 vital capacity. He can go all day without using a ventilator. In fact, I've got another patient who's a lawyer and argues cases in court, frog breathing. He has no ability to breathe without frog breathing. And he doesn't even take a respirator with him to work during the day. He just takes 3 gulps, 200 milliliters per gulp, and he argues cases in court that way. One study they did was they frenectomized baby baboons. And they didn't give them deep breaths. Now you're wondering, what does this have to do with the baby baboon? Well, I lecture a lot in Europe, and they don't have these fellows in Europe. Well, at least they didn't. Now they do. But it's not because they wanted them. Raccoons now are spreading all over Europe because in 1936, I think it was, Hans Goering, the Nazi, had them imported because in German they're called Waschbärs because they wash their food before they eat them. And Goering used to love to shoot bears, and there weren't any bears left in Germany, so he imported these Waschbärs to shoot them, but he didn't get them all. So now they're spreading all over Europe. But anyway, Up until recently, I was able to get away with this slide because the Europeans never seen a raccoon, you know. What they did was they frenectomized these fellas, and without giving them deep breaths, all these babies, animals, developed small chests, obviously. And all of our kids would develop pectus excavatum, small chests, if they're not put on high-span BiPAP. Okay, let's look at coughing. Mucus plugging is what causes all the problems. Because patients do fine until they get a cold, and then because they can't cough effectively, they get pneumonia. And the lung collapses, and I told you the first part of a cough is a deep breath. So if the vital capacity is under 1.5 liters, you've got to inflate the patient first, and then you do pressing on the belly to help their cough. It's a little bit like a Heimlich maneuver. And if your care provider does not have any use of their arms, don't worry about it. Just have him use his head. That works too. Okay? However you do it, you've got to press on the belly. And then what we do is we measure those cough flows. Those are assisted cough flows. We cough them through the peak flow meter, and the difference between the assisted cough flows minus the unassisted cough is a direct function, a direct correlate of bulbar muscle function, just like the MIC minus the VC. Objective and very useful, but not too many people are familiar with it. Now, look what happens when you do assisted coughing. The cough flows go from where they're not effective. At under 160 liters a minute, you cannot cough anything out. If you get a cold and that's all your cough is, you're going to get pneumonia. I'll tell you right now. But once you get to 160 or more, your cough becomes effective. And that's why we never have to trach anybody. Nobody needs to be trached for ventilation. I can ventilate comatose patients in iron lungs. I can ventilate them using lip seals. But getting airway secretions up is the important thing, and that can be done if you know how to help somebody cough. We use a cough assist device, which is a little bit like a vacuum cleaner. First it gives you a deep breath, then the pressure drops, and the secretions come flying out with 10 liters per second of flow. And people ask me how young a patient can use this on. Well, our babies, it's used on them, but you got to time it to their breathing. How much does it help them? It's not clear because they're often hospitalized twice a year until they're 3 years old anyway. But once they're 3 years old and they're able to cooperate with this machine, they're almost never hospitalized anymore. And our 100 patients with spinal muscular atrophy, for example, the hospitalization rate until the 3rd birthday is 1.6 per year. From the 3rd to the 5th birthday, it's 0.3 per year. After the 5th birthday, for SMA type 1 Wernicke-Hoffman's patients, it's only 3 per 100 years. And these are patients that are every bit as severe as the most severe infantile Pompe's disease patients. So when a patient's about 2.5 years old, usually they're cooperative with the machine and it works well. This is an old patient who you see the mucus plug came flying up into the interface and we remove it. This is a 2.5-year-old whose trach was removed. Sometimes patients can use it on their own. Now this is, of course, our favorite cowboy. And he had a trach tube in, which is why he couldn't breathe. In fact, if he didn't have a trach tube, he would have absolutely, without question, been able to breathe during the day. But he was very busy giving interviews. At any rate, he also, wherever he went, though, he brought the cough assist with him because he understood that using that through the trach tube was much more comfortable and effective than being suctioned. So even though I don't recommend trach tubes, the machine is also quite useful if you have a trach tube. But of course, it's better to not have a trach tube in the first place and use the machine so that you don't need to get one in the first place. Shaking up the chest can be helpful too. There are very expensive devices, Hayek oscillators and therapy vests and all that cost $20,000 to $30,000 sometimes. A $400 chest percussor or vibrator is just as effective. And now the final goal is to maintain normal ventilation. Now how do we do that? Well, the diaphragm is like this poor horse. When the diaphragm is weak, it's going to collapse if you don't give it some rest. You cannot give it rest by giving continuous positive airway pressure, CPAP. You cannot give it rest by giving the patient oxygen. You can only give it rest by applying pressures to the body or the airway. How do you apply pressure to the airway? By positive pressure when the patient inhales takes the work of breathing away, but not by using a low span on a BiPAP machine. By using an inspiratory pressure of 18 to 20 centimeters of water. The expiratory pressure on a BiPAP machine is not only useless and uncomfortable, it actually subtracts from the inspiratory pressure. in what your goal is. Your goal is to take away the work of breathing and to give a deeper breath. So BiPAP should not be used for people who can air stack. It's a little technical, and I haven't got much time to go into it, but BiPAP is not ideal, although we use it for children who are too young to be able to stack breaths, and I use it for bulbar Lou Gehrig's disease patients because they can't stack breaths anyway. But in general, volume cycle ventilators are better for people who can cooperate because they can hold a breath, get another volume of air, and go all the way up and get a deep breath. And it's more comfortable because there's no expiratory pressure. And you can adjust the flows. It's more comfortable for that reason, too. So the ventilator is actually like the pickup truck. It rests the horse, and then during the daytime, you can breathe on your own. And that's almost always the case. Now, what's this? This is a pneumo belt or an exsufflation belt. An exsufflation belt is a girdle with an air sac in it. The air sac is attached to the ventilator, and it goes under the clothes, so it's very good in appearance. There's nothing in the nose, the mouth, or the neck. And it ventilates the patients very nicely, provided that they don't have too much scoliosis. That's the trick. But it works very well. As you see, you don't see anything here. It's under his clothes. What about mouthpiece ventilation? Well, in 1530, an Italian physician by the name of Paracelsus took his chimney bellows and inflated his patients who were short of breath or dead. And it was so successful, at least for getting paid, that for 300 years doctors had this, a chimney bellows, in Europe in their offices. And when patients were dead or short of breath, they would be inflated that way. Now again, I never saw any outcome studies on this, but they must have gotten paid for it because it was used for 3 centuries. You can also normalize your ventilation briefly by breathing on your own with greater effort. But when the carbon dioxide goes up, that means that your brain is telling you that you cannot afford to maintain normal ventilation because your muscles will get tired. And we can't afford to have our diaphragms tired. So the brain has you underventilate, the CO2 goes up so that your muscles don't get tired. This is bad because it's a very bad cycle. It's a downward spiraling cycle. The CO2 can go up so high that you stop breathing altogether. And it will if you treat this with oxygen, much sooner than if you don't. What is the solution? Well, you can get a mouthpiece there, and you can have the patient supplement his breathing by getting a deep breath every now and then to maintain a normal oxygen saturation and a normal CO2. It's as simple as that. And when patients use nighttime ventilation but they get weaker, that's basically what they do. They start using the mouthpiece a little during the daytime, and they maintain normal ventilation that way. As long as the oxygen saturation is 95 or more, the carbon dioxide is fine. Patients are not symptomatic and they're okay. But if the carbon dioxide going up causes the oxygen saturation to go down, the patients are symptomatic and they need help. So these are patients using simple mouthpieces. This is a patient who has actually been doing this since 1947. 24-hour non-invasive ventilation with a sip and puff motorized wheelchair and the mouthpiece there. She's been in the community living on her own, alone, with 24-hour attendant care that she hires, trains, and fires since 1979. And you can visit her. She'll be happy to say hello. I have many patients like this. Here's a patient, 45 years, same thing. No ability to breathe whatsoever. You will never see a trach tube in their necks. This is a patient with a gooseneck clamp holding the mouthpiece next to the mouth so that he can rotate his neck and grab it whenever he wants it. And our 44-year-old Duchenne patient with a microphone holder, again, holding the mouthpiece there, and he's been doing this now for 19 years. For babies over the age of 6 months, Respironics has a small nasal interface that works very nicely for them from the age of 6 months to 4 years. However, at under 6 months of age, there's nothing on the market. So our respiratory therapists construct from a Hudson CPAP prongs and a nasal bridge piece from a CPAP circuit this nasal interface for children who are under 6 months of age. And it works nicely. And how do you know that it's working? Well, we have to let the parents do all the work. If you want to, I always tell the parents that you have 3 choices. You can let nature take its course, and, the child will die. You can trach them, which I don't recommend, or you can try to help their inspiratory and expiratory muscles and use these non-invasive methods. Now, usually when people come to me, they know that that's what they're going to hear, so they usually want to do that. So they have to do all the work, though. So we set the patients up at home. The respiratory therapist brings the equipment there, And we tell the mother to put the nasal ventilation on when the child is in deep sleep. And within a week, the kids won't go to sleep without it anymore. In fact, very often the kids are flushing and sweating, and they wake up frequently at night. And when they start using nasal ventilation, that doesn't happen anymore. They sleep nicely. And usually the kids very quickly know that this is benefiting them and they use it. In fact, you'll hear them grunting a little. With a deeper breath, they go, ugh. And that's actually, they're using the air to cough out secretions on their own, even at less than 1 year of age. Nasal interfaces are very common. They're on the market, and I'm not going to tell you stories about all these folks. By the way, right now, these kids are not using this nose piece because it interferes with their vision. The nasal air is actually what they're using. And Virginia, where are you, Virginia? Oh, okay. Virginia is actually using a nasal air. Isn't that a nasal air, Virginia? Yes. You see, she could wear glasses, and these kids can wear glasses, and that nasal interface will not interfere with their ventilation. Now, Virginia, didn't we try a mouthpiece? Can't you use a mouthpiece? Well, why do you prefer to use a nasal?
Well, we were just to see you on Thursday, so I haven't had enough
Time to try it, okay. But you see, normally, usually for daytime aid, it's very practical just to have the mouthpiece near the mouth and use the machine that way. Now, everybody has a different type of nose, so don't expect one interface to match to be good for everybody. So I'm just going to show you these quickly, but this is not important. Nasal ventilation, some air will leak out of the mouth. Patients will desaturate. The solution for that is the lip seal. The lip seal works better than nasal ventilation, but most people prefer nasal because the mouth is free. And the lip seal will normalize anyone's ventilation. Is that 30 minutes? Over. Oh, my. All right, well, then let me just stop by showing you. This protocol is very important. Everybody with Pompe disease should have an oximeter in the house. Because when you get a cold, you put that on, and you don't let the oxygen go below 95 by using assisted ventilation and assisted coughing as necessary. And you won't get pneumonia, and you stay away from doctors and hospitals because they'll kill you. And we published papers on this. The other thing that's very important to say is that this is not going to work very long if you don't have the cooperation of your intensive care doctor. Because if you get pneumonia and go in there and they intubate you, and the intensive care doctor thinks he's got to put a trach tube in to extubate you, it's not going to work. So on my website, drbach.com, there are 2 articles on how to do the intensive care management of patients with infantile neuromuscular disease. See that the intensive care doctors get them so that they know what to do for the kids when they get sick. And of course, I have 10 books. This is the last one, Management of Patients with Neuromuscular Disease, Non-Invasive Mechanical Ventilation, and so on. Okay, thank you.
While I'm waiting for this, I'd just like to say thank you for the opportunity to speak today, and that I've had the honor of just getting to know so many amazing patients and family in the last 3 or 4 years that I've been working with kids with Pompe disease. And I think all of this information comes from them and the parents that are such phenomenal teachers, that they do such amazing things with their children that I just want to honor them, and most of the ideas and the cool things come from them. So therapeutic intervention guidelines for children and adults with Pompe disease. This is a big topic for 30 minutes when we're way behind. So make it 20? I doubt I can do that. So I'm using as the foundation for my presentation the World Health Organization that developed a model, and it's the International Classification of Functioning, Disability, and Health. And what it really is to me is really, it's designed to really look at how people live with their health condition in terms of function, participation in their home, community, and work environments. And really that the focus of therapeutic intervention should be on function and using the clients' and the family's goals to really guide what services you choose and how to measure your outcomes. So I'm going to use functional classification to determine the intervention strategies, and to use activity limitations and participation restrictions. So as we've been hearing all day today, the heterogeneity of this group is incredible. And what I would like to do today is divide it into the 4 groups that you see there and talk a little bit in each group about what the function is for that group and what the therapeutic goals would be for that group. I'm also going to refer to the GMFCS, which is the Gross Motor Functional Classification System. And it's probably one of the most well-known ways in physical therapy in which we classify children in terms of function. It was originally designed for children with cerebral palsy and now has been normed on several other populations. So from a 1, it varies from somebody walking without restrictions down to 5, which is self-mobility being severely limited. So this is severely impaired, which is a level 5. So the first thing you see when you look at the video is that this little boy has hand grasp. He can hold onto the block. He has minimal upper extremity function, and he's particularly challenged to do that movement against gravity. He's dependent for all his activity of daily living. He has no independent mobility, and he tolerates being in supported sit either in his wheelchair or in a positioning with his mom or his dad. The important thing, I think, in this group to really think about when we're thinking about function has been touched on a little bit, and to me, it's really the non-limited communication. And this little boy has very good communication. He's able to say a yes and looking up with his eyes, and a down with his eyes looking downward is a no for him. And as he grew, he got much better at this, and I was able at age 3.5 to even do his cognitive testing and show that he has normal cognition. And he also has one of the very fancy computers that we've heard people refer to, where he has 4 quadrants, and he's learning to scan the 4 quadrants to be able to make choices. So the key thing I really want to highlight with this group is function, and function in terms of communication and being able to sit upright and communicate to other caregivers in their life what their likes and dislikes are, if they're in pain, what choices they want for play. So what are the goals of therapeutic intervention in this group? Toleration to upright sit in order to have social interaction and educational play opportunities, improved communication, and increased functional grasp on toys. And that may mean that you have to work in gravity-assisted positions, so either with slings or with some kids, for example, in order to get them to use a marker in their hand, we've had to build up the marker because they only had a small range functional grasp. Anything that allows them to interact in their world successfully. Activity limitations for this group is obviously decreased endurance and a lot of physiological instability when they're in upright sit, and a lot of that being increased secretions. And compromised postural alignment. I think this is key as we talk about ventilatory issues with this group. And so the kyphosis and the scoliosis, as soon as you get a curve in your spine, you're further compromising your GI function as well as your respiratory function. And so I think that's really critical in this group. And if you think of how a scoliosis would take your head to the side, that also really impacts how you can visually engage in your world, how you can use that communication, how you can use your computer, how you can do yes and no. So the other complicating thing that we found in this group as well is fractures. And so this little girl has had several femur fractures, and her mom is here, and she's adorable. So you can see that fractures also limit positioning. It makes it difficult to put her in prone, to put her in a wheelchair. If her knee needs to be extended, you can't put her upright and get her in her chair. And just ventilators in themselves in this group make it difficult to position in different positions, and difficult to get out in the world if you don't have a seating system that allows, a stroller that allows you to have the ventilator on it, or a wheelchair that you can hook up your ventilator to go out with. The next group is a functional sitter, and it's a GFMFC4. So you can see this little boy here. He can sit, and he can transition in and out of sitting. Some of the children bum scoot that are in this group, which just means they go backwards along on their bottom. He can momentarily lift up his hands there and sitting. But prone is really difficult for him. You can see there that he doesn't want to go there. It's hard work for him, and he's also really tight on the front of his hips. Mobility, we also see that they can usually propel a manual wheelchair or have power chairs. Supported standing, moderate assistance is required for this group to be supported standers. And that may be in the form of knee immobilizers, which he does stand with knee immobilizers now. And obviously upper extremity strength is greater than lower extremity strength, and developmentally age-appropriate fine motor skills. So this little boy, just because it's really interesting, was reading Harry Potter when he was in kindergarten. So he's extremely bright, and he does have an augmentative communication system as well as he is verbal. He runs the show. Goals in this group, obviously sitting quality is essential because we want to maintain good postural alignment in order to maximize functional play with the upper extremities. So good alignment in order to play with toys, participate in dressing, and all activities of daily living. Mobility, we want independent mobility in the homeschool environment, and that's fine as bum scooting and crawling, but they need another way in which they can have more independent propulsion, and that's with probably the use of a wheelchair or a power chair. The other thing that comes up in this group is maintenance of a standing transfer. So as the kids get bigger and heavier, it's absolutely key, if we can, to be able to maintain some weight bearing, because they're easy to pick up when they're 40 pounds to a certain extent, but they get to be 80 pounds and 90 pounds, and you have to have started working on a standing transfer when they're very young to be able to maintain some ability, even if that means that they transfer with use of knee immobilizers or assistance there to get up to standing. We expect minimal change in standing and ambulation due to contractures, postural alignment, and weakness, as well as minimal change in being independent in transfers. And the reason for that is really when we look at the role of prone and standing. So when you look at typical development of this baby on the left-hand side here, that's a 6 months prone position. You see that that baby has what I call co-activation. The baby is working on the back in their back muscles and into the hip, as well as the stomach muscles, and that provides that stability there. But what it also does is lengthens that whole front of the trunk. And that baby will then go into crawling and up into standing. And before she's walking, she will have had a lot of time in standing doing the same thing, elongating the muscles on the front of her trunk and playing in a position where she has co-activation of her back muscles and her hip muscles together with her front muscles. And what happens with kids that are functional sitters is they learn to be functional and play with their hands in that position, and they lose the opportunity to elongate these muscles on the front of their hips. So you get short, tight muscles in your hip flexors and weak, long muscles in your hip extensors or your muscles in your butt and your back. And so you have this imbalance that it just gets more and more complicated over time because they want to sit and be functional. So I'm not going to go through this whole chart, but I think to me the most important thing in it is if you look up at the top for a child that falls between a functional sitter and a child that has mild developmental delay, there's this critical developmental period that I like to explain it as when a child can get any type of autonomic instability problem. It often in this population is a respiratory incident. But what happens is that child ends up spending time on their back in the hospital. And their choices once that happens usually are they're in supine position on their back or they're in sitting. And kids want to be functional. They maintain the ability during that to play with toys with bimanual play. But they lose the ability during that time to roll in and out of sitting and to get on their stomach. And also, there's less and less need to play with their feet and do things with their legs during that time. And so they're still growing, they're getting bigger. So you have this short muscle that's a little bit weak already in the legs. And then you have legs that are getting longer, and it takes much more force to move them. And so the other thing that happens is after kids pass by a certain age, they don't get prone anymore. So in typical development, once a child can crawl and sit well, you don't see them playing very much on their stomach. And there's good reason for that. They don't play on their stomach because they can't use their hands. If you're down on your elbows, you can't manipulate toys, and you also are on the floor and you can't visually see what's going on in your world. So we lose that piece of time when the child would developmentally develop a lot of those prone skills. And after that, it's very difficult. And so you can see they get the contractures that we typically see from being on your back and from disuse and inactivity in the legs, the frog legs, the tightness in the front of the hips, the plantar flex feet. And, oh my. And what happens from there, it takes a lot of therapy and adaptive equipment and potentially even surgery to move out of that category as being a functional sitter. And so that's why I'm saying it's very difficult in that group, once you're in a wheelchair, once your primary function is sitting, to become a stander or a walker. So here's another example of a little boy. And I just want to highlight with him is that you can see he has casts on. He was already tight in his heel cords, and so they're doing serial casting to elongate his heel cords there. You can see he can roll, but what's key to me here is that he's pushing up and he's elongating the front of his trunk and working on the strengthening between the front and the back, and he's working really hard to try to get up into his hands and knees to crawl. But just look at how much his hips are working in that position because he's stretching all the way out. And what happened to this little guy is he got a bug, he got sick, he spent a lot of time in the hospital, and he got all these contractures. I mean, it was that example that we just talked about. When you have a postural kyphosis or you're rounded like that, it automatically impacts where you reach to. So instead of your reach being to here, as soon as you round out your back, your reach is only in this range here. So it changes your upper extremity function to start with. When you have a wide base of support like he has and tightness on the outside of your thighs, it makes it very difficult to move in and out of sitting to crawling. So then you become very immobile in sitting. When you have a backwards or posterior pelvic tilt, it's very difficult to do a standing transfer because you can't move yourself forward even if somebody's in front of you helping you. And the lower extremity contractures limit your standing opportunities, so it makes it very difficult to get this child up into a standing system. The next group is ambulators with assistive devices, and it's the FCS3. So you can see this little girl crawls, but when you look, you can see the weakness in her trunk, that she has some concavity, and then her lower extremities are a little bit weak. She has a little bit of a wide base of support in her arms. And she's a short distance ambulator. She puts on what's called RGOs, and I'll show you a picture of it. They're called reciprocating gait orthoses, and they help her to, she has to lean slightly backwards, and it allows her to bring through her feet to step. But what's really key with her is that she's got all these great transitional movements. She can go up and down the stairs at her house. She can get onto the furniture. She can get into her bed that's just a little bit off the floor. And she has developmentally appropriate fine motor and cognitive skills. So there's an example of bum scooting. So showing, what do you want me to do now? Do I have to put my legs out? And then you see her quickly up and standing as well. She's long sitting right there, and just to note that that's also a very important position in this group for lengthening out the back of the legs and for late onset as well. I just wanted to show there that her hips are still tight. She had surgery to lengthen her hamstrings and her hip flexors and to realign her hips. So it really helped her functionally in terms of all the positions she can go into, but she's still tight in the front of her hips. And she very much did not want to do this for me, so you can see she's a little bit upset with me. come on, I don't want to. And she also didn't have her right walker. It was at school. So I guess if I don't touch this button, it shuts down on me. So goals of therapeutic intervention in this group are functional independence and transitional movements, independent transfers in the bathroom. So even though she has all this mobility, they haven't figured out a way yet to get her to independently get up on the toilet. Improved endurance and efficiency of ambulation. So she's going to have to be way more efficient with her walking in order to walk in the classroom at school, even though she's working a lot on it with her school therapist. And also having an alternative mobility for age-appropriate social interaction. So she has a power chair, a lightweight wheelchair, and she has an adaptive tricycle that she uses. They live on an acreage. To get back and forth to her grandma's house, she uses the power chair. And this is just a point here, is that all of these kids need to move, and having some form of independent mobility is absolutely key to cognitive development. In terms of even spatial cognition, they say that there's a difference in how children have memory for an object. So a child that's been moving independently in a wheelchair or through walking will localize an object in terms of a piece of furniture. So they'll say the toy is beside the sofa, whereas children that have had less mobility experience will only be able to localize that in terms of their own body. And so it's so important in terms of the cognitive development and an understanding of who you are in space. His dad's here too, little cutie, pushing that wheelchair. Activity limitations, we talked a little bit about this already. Obviously, contractures and that muscle imbalance, the time spent in sitting versus standing, energy consumption, and mobility is dependent upon how much adaptive equipment you have, or whether you have orthotics. So the last group within the infantile that I'm looking at is the ambulators without assistive devices. And I think it's just important to kind of look back here to typical development and how are these kids different than the babies we see here. And I'm going to show you a little girl here very briefly. So when we look at this group of children, we measure strength when the children are on their back by their ability to play hands to feet. And she does pretty well with that. She can get her feet up to her hands. But when you see her over in prone, this is a really difficult position for her. For her age, she has a difficult time with a sustained head lift and really having good activity of her tummy muscles and her back together in this position. And that may also be that a lot of the children at this point lack experience in prone because of multiple hospitalizations and that physiological instability. And it's already, we've already talked a little bit about the fact that they may maintain a head lag as well as have a decreased demonstration of standing in the early period. So here's another child, only he's a toddler. He's great to watch. And so what we see in this group is that there's subtle compensatory patterns to increase stability. When you see him come down the stairs here and jump, he lacks a little bit of grading. So he can jump, but he can't really slow himself down from there. And he's a great little walker, but he just hangs on to his arms a little bit to gain stability here. And you see he's up on his toes a tiny bit. Now for his age, we would expect him to be able to stand on his foot. So it's really, on one foot, it's really subtle. He can just lift it up for a second. He can jump. A good measurement of strength is the ability to transition from the floor up to standing. And so we would also expect around this age that he should be able to transition without use of his hands. And so he should go through half kneel with one leg up. And you can see there that he had to put down his hands in order to get up from the floor. So the goals for this group are safe ambulation on varied ground surfaces and acquisition of age-appropriate gross motor skills. What are some activity limitations for this group? Now this little girl can walk without a walker, or could at the time of this video, but I put her in here to really show what was going on with her feet, because there's so much we don't know about what's happening in terms of imbalance in the muscle. And a number of the kids had what I would call really funky feet. we would see, like for her, you see that she has a really strong muscle pull that's turning her feet in, and it's not balanced by a muscle pull that's pulling them out the other way. And so she's got this position in her feet that they're really pulling in. And when her mom says to her, put your feet flat, she can get them flat, but she can't walk and have the motor control to keep her feet flat. And so she has little braces that she wears to help her with her alignment in her feet. And this little girl, you see a lot of maintenance of stability patterns. So she's an ambulator, and two things we see here is very enlarged calf musculature. So if you look at the back, she's got really big calves. And when you watch her walk, she has a little bit of a lordosis in her spine, a little bit of lateral sway, you can see. She hangs on to some stability patterns, and that helps her to be functional. She's a little bit flexed at her hips. Now this is very similar to late onset Pompe in terms of she's very challenged to climb the stairs. And so she's really frustrated here because her mom's at the top of the stairs calling her up, and she wants to do it, but it's really hard work for her. And so eventually she puts down her hands and she finds a way that works for her. And then the last group I'm going to look at, even though I think there's crossover in late onset to some of the other groups I've already spoken about, is late onset. And I think the mobility is really variable here. There can be independent ambulation with or without mobility aids or orthotics. Again, difficulty climbing stairs and going from sit to stand. You can see here that he, oops, I'm going to go back. If that video will run again. He's having, has to use his hands to get into sitting because of lack of trunk strength. And what's really key in this group, I think, is energy expenditure. We've talked a lot about that already, but fatigue, respiratory insufficiency that's greater than cardiac, and proximal weakness, especially in the diaphragm. Therapeutic intervention goals, independent mobility in the community, home, and work environment with the least restricted orthotics and mobility aids. Activity limitations. Obviously the weaknesses that we already talked about, and the skeletal deformities. And I think here I would just like to, because there's a minimal amount of time, talk a little bit about plantar flexion contractures, because I think they really impact this group. And I think it's just important that if you have tightness in your calf muscles that take you into position when you're up on your toes, it takes your whole body forward, and you're going to have to compensate somehow for that forward shift. So what you will do is you will either pull your arms back or arch in your back, or else you will fall down to the ground. I mean, everybody wants to stay upright and be mobile, so you adapt strategies to do that. And what's key about that plantar flexion contracture is it will change the way in which you walk, because when we walk, our upper body moves over a stationary ankle. Like your foot is on the ground and you come forward, can't go too far forward. And if you look at my ankle here, it's bent a long ways into dorsiflexion. It's that forward movement. If you have a contracture in that calf, you can't have that forward movement or that momentum as part of your gait cycle. So if you're up on your toes and you're tight in your hip flexors, your work of walking is so much more difficult, and your step size is so much smaller that it will take twice as much energy to walk the same distance. So irregardless of whether you're weak in your muscles, maintaining that range of motion will dramatically change the ease in which you can walk. Respiratory insufficiency, I'm not even going to go there on that point right now, because I think we've talked a lot about that in terms of diaphragm weakness, and I'm going to talk a little bit under strengthening in terms of that. But again, falls risk is also complicated if you don't have good range of motion in your heel cords. If you're going to fall and you're tight, you're not going to be able to catch yourself out on your hands if you don't have the range of motion in your ankle. You can't reach downward to pick up something off the ground if you don't have the range of motion in your ankle. Okay, therapeutic intervention. I'm going to just talk briefly about a couple things here that I think are really important to the group. Function. It has to be about function, what you decide is appropriate for you. And that looking at what the piece of the puzzle is that you're missing or that you need in order to either maintain your function or increase your function. And it can fall into range of motion, strengthening, endurance, or maybe it's even that you need adaptive equipment that you don't have. So we know all the reasons that we have contractures in Pompe. I'm not going to go through those right now. And here's the typical muscle groups that we tend to see contractures in. But what I want to focus on here is the 4 categories below. In terms of range of motion for a child that's severely involved, I think the most important thing is to maintain trunk mobility and to really work on having mobility in your rib cage and spine so that you can have more optimal respiration and GI. So as soon as you get that scoliosis, that impacts so many things. Sitters, I think it's equally important to work on the trunk mobility, but at the same time, in order to do a standing transfer, you have to maintain the range of motion in your legs in order to be able to do that forward weight shift and do that standing transfer. Ambulators, we talked about the energy conservation piece of it and how you really need to maintain the range of motion in both your ankle joints and your hips. And the high-functioning children, they need to maintain that range of motion as well, because they need to be able to adapt to ground surfaces. And you can't do that if your foot is just locked into one position. Strategies in terms of stretching and positioning. Functional elongation is always the first thing that I recommend for people. If anybody can incorporate long sitting or use of prone or use of a standing system into your life, you're going to be so much more successful if you say to that family, can you watch Arthur and sit in long sitting every day? Finding a way to make it part of your life and get that stretching each day. And there's just one interesting study that it's kind of been used by therapists for many, many years, and that's the study that I'm looking at that I quoted down here by Tardo. And what's important about this is he looked at children with cerebral palsy, and he looked at typical children, and over a 24-hour period, he measured their ankles and how much tension there was in their ankles and what their range of motion was. And what he found was typically developing kids, they spent 7 hours a day having some stretch on that ankle. And children with cerebral palsy that maintained their range of motion had stretch on their ankles or tension in their ankles for about 6 hours. And children that had development of contractures or decrease of range of motion fell below that time. And so I think that's important for us to think about when we're looking at especially functional elongation. And here's an example of a stander, and just the benefit here of this stander is really twofold. The elongation on the front of the trunk, number one. You know, it's allowing his ankles, his knees, and his hips to be stretched. And it's dynamic. His strap is loose on there, and he's going to the side and coming back up again, which is helping him to also work on strengthening. The key here, too, is when he's in standing, his spine is beautifully stacked straight. But when he's in sitting, it's really hard work for him to sustain that upright position. So it allows him to have a way in which he can work on strengthening his trunk with nice alignment. I'm just going to skip this slide here. I mean, all we basically know by looking at other populations is that stretching and positioning do work, and there's a lot of question about how much time you need to stretch to make that work. And so we're going to just shoot for at least 30 to 60 seconds from the research if you want to have a passive stretch. Strategies for range of motion. The least restrictive orthotic in order to improve alignment and efficiency of gait. More is not better always. You have to look at the weight of it. If the orthotic is really heavy and it's too heavy and it's making it more difficult to walk, then it's not beneficial. You have to look at how it's changing the walking pattern. And I'm a huge advocate of articulating AFOs. And for some reason in children we use articulating AFOs all the time, and in the adult population we see a lot of non-articulating AFOs. So if you think about what I talked about in terms of that walking, if you can't move your ankle joint, it's going to be a lot more work to walk and to go downstairs and to pick up things off the floor. And so really looking at articulating AFOs. Think about two joint muscles too and how that plays out.
Sorry, I wonder if you could sort of...
Can I do just a little bit on a couple more things here?
I think we want to hear the next speaker
Okay.
as well.
So you can see that this little boy just had, we're taking away gravity here. I just want to talk really quickly about EMS because a lot of people are interested in that. The research shows that it works in other populations, and there's a lot of question about it. We can increase some range of motion with it. We can increase some force with it. We don't know how it applies to Pompe. If you'd like to kind of talk a little bit to me more about that later on, I'd be happy to talk to you about it. But I think we can think about using it in the trunk in terms of improving alignment and increasing strengthening, and as well as really looking at that dorsiflexion and can we use it to help the range of motion in the heel cords. Cardiovascular, we haven't even touched on that. That's the last topic that I have in here. I'll say 2 minutes to it in terms of that. We're looking at submax exercise rather than maximal exercise because of the energy substrate that we're using. And the key to figuring that out is that for adults is the Karvanen formula in terms of you want to take your 220 minus your age to get your max heart rate, and then you can times that by 0.65 in order to get your target heart rate. The formula here, you can Google it, and what it does is it accommodates for the fact that everybody has different resting heart rates. In children, it's questionable what you should do, but there's also the Omni Scale, which is a picture scale, which can give you an idea of what moderate exercise might be for kids. And in terms of frequency, we're aiming for 65%, 45 minutes, 2 to 3 times a week. Because they can improve efficiency if you go, studies show 60 to 80% at 2 workouts a week. And so if you lower it down from 70% to 65%, you have to do a little bit longer workout. And then here's just the implication for all the different groups. Each functional group needs to work on cardiovascular endurance in a different way. So even the tiniest guys need to work on sitting upright and doing their cardiovascular endurance that way. Whether you're pushing a wheelchair, whether you're working on a treadmill, having all the kids work on cardiovascular.
Sorry to rush you. I think
It's so late,
very-
and it's been so long.
It's a very important area because even after enzyme replacement therapy, because you're going to have to deal
Right.
with that as well.